Hi,
Good
everyone.
morning, everyone.
Having a little Zoom glitch, so bear with us right now.
Eliza, can you hear me?
Yeah, I can hear you now.
Okay, perfect. Um, Hi, everyone. Sorry, we're having, as Eliza said, a bit of a Zoom glitch. But good morning. Thank you for joining us for Virtual Insights on Kidney Transplant. Our topic today is pediatric kidney transplant. And our speaker is, as you well know, Eliza Bensley, who's the clinical transplant educator. We encourage you to submit your questions in the Q&A section. Today's session will be recorded and sent to all those who registered, and it is my pleasure to turn things over to Eliza.
Hi, everyone. Thank you so much for attending today. We're going to actually talk about pediatric kidney transplant, pediatric kidney transplantation, and we are also going to talk about living donation. So I'm going to start off our webinar with a wonderful video.
Hi, my name is Sanique and I'm 13 years old and my mom donated her kidney to me.
Hi, my name is Rayniqua. I'm Sanique's mom, and as you just said, I'm the donor.
I had my kidney transplant when I was at 6 years old. I was scared because I was afraid I wasn't gonna. It, it changed good because at least I'm healthy now. I could eat much better and I could run a lot. Have hope. Stay confident about yourself.
It was an honor to be a donor. I'm helping my child with her life. I'm giving her another chance at life. So it was awesome. It was a rocky road, but it was awesome to be able to do that. There has been fears being a donor because anything could happen, but gracefully it didn't. So biggest thing was, what if the kidney didn't work for her? What if the kidney rejected? But so far we're 7 years strong and kidney is still good. Changed a lot. Like I said, we no more Christmases at hospitals, no more Thanksgiving at hospitals. No more dialysis, no more pain. It's just been great since the transplant. Because after doing research, New York Presbyterian is one of the best hospitals. They have the best doctors. So I figured, why not go with the best? Because that's what my child deserves. Absolutely, I've already have. I've recommended plenty of people to come here and look into the transplant programs, whether it's kidney, heart, liver. I just feel like this hospital is the best when it comes to care.
Okay, guys. Well, this is an amazing video that we did with our pediatric patient, Sanique. And as you heard in the video, her mom was the donor. So I think it just kicks off things nicely and sets the tone for the webinar. Um, so we're going to just talk on overview and start out by just reviewing some data. This is a graph of the adults on the kidney transplant waiting list. As you can see, this is from 2022, but we had almost 150,000 adults on the waiting list. And when we look at pediatric patients, which is 18 patients 18 years and younger on the waiting list, those are considered PEDS patients. You can see there's significantly less PEDS patients on the waiting list. In 22, there was a little over 250, sorry, 2,500,000 2,500 patients on the waiting list. So just to review some of the major causes of kidney disease in pediatric patients, congenital anomalies, that pink line, that's like our most common cause. And then we have other causes such as glomerulonephritis and FSGS. And then there's a significant amount that are unknown. But in general, we really do see most of our PEDS patients who have congenital anomalies, which are basically birth defects that you were born with, and they can keep the urinary tract from developing normally, and that's about 60% of childhood CKD cases in the US. A couple ones that we know of are called renal agenesis, when a baby is born with missing one kidney or both kidneys, and then kidney dysplasia, when parts of one or both kidneys don't develop normally while a baby is developing in the womb, and then renal hypoplasia, when a baby is born with one or both kidneys that are smaller and have fewer nephrons than normal. There are, of course, other causes, much like adult kidney disease, hereditary diseases such as PKD, polycystic kidney disease, Alport syndrome, infections such as HUS and nephrotic syndrome, and then systemic diseases like lupus and trauma, urine blockage and reflux. But basically the purpose of this slide is really to tell you that we get a lot of our pediatric patient referrals from pediatric urology and of course pediatric nephrology, but we follow our kids very, very early. Kidney disease is not that common in children, but there are children that are more likely to develop kidney disease. So chronic kidney disease is more common in male children than females. And then in North America, Black children are 2 to 3 times more likely to develop CKD compared with white children. So again, there are about 2,500 kidney transplant pediatric patients on the waiting list. This is from 2022. And as you can see, only about 700 kidney transplants were done in 2022 in children. So there's a disparity. And that means that there were fewer transplants done as compared to adults, of course. And why is that happening? Really, the problem is the organ shortage. And this is a problem that the adult patients face as well. We have a significant amount of patients on the waiting list, and we have a significant amount of people that need a transplant. And unfortunately, we just don't have enough organs. So I think this graph kind of really speaks volumes when you look at the deceased donor transplants done and living donor transplants done and compared to the amount of people on the waiting list. So what can we do to address and try and help the organ shortage? Well, one, we can really focus on living donation. And we do educate heavily for our pediatric patients, especially knowing that our PEDS patients are not typically going to have one transplant in their lifetime. They may have 2 or 3. So we're really focused on educating on living donation. We educate on kidney pair donation and advanced donation, which we'll talk about a little later. And then, of course, there's deceased donation. We do have some PEDS patients that don't unfortunately have a living donor, and they do get a deceased donor. But one of the strategies, especially for the adult patients, is utilizing these expanded criteria donors, such as donors that have high KDPI scores, kidneys from donors that have HCV infections, and PHS increased risk. But a lot of this isn't super appropriate for our PEDS patients. So again, we really do focus on helping them try to find a living donor. So according to the Scientific Registry of Transplant Recipients, 40% of children in the US will receive a kidney transplant within 1 year of listing, while over 25 are still waiting after 3 years. The reason why we, again, push living donation, especially in our PEDS patients, is there's limited waiting time. We can schedule the surgery to optimize the recipient health, and then we can preempt the need for dialysis, which we want and encourage with our adult patients as well. We know that delayed graft function is less with living donor kidneys in compared to deceased donor kidneys. We have the brain dead patient donors here, and then donation after cardiac death but the risk of DGF is significantly lower with a living donor kidney. And graft survival is superior for living donor kidney transplants than deceased donor kidney transplants. So this graph kind of outlines the percent of graft survival post-transplant. And as you can see, the living donor bar is higher. And this graph really just represents how much longer a living donor kidney can last versus a deceased donor kidney. They kind of last about half the time. And this is not to say that a deceased donor kidney can't last long. I have seen patients whose deceased donor kidney lasts more than 20 years. It can happen. It's obviously just depending on the patient situation, but we know living donor kidneys last longer. And that's really important for our PEDS patients who, again, they are needing their transplant so early on in their life. They're getting their transplant young. And so we know that they probably will need another. So the longer they can have their initial transplant, the better. So what strategies do we apply for our PEDS patients who don't have a living donor? Much like the adults, we push our microsite program. And this is our free website that you can create to spread the word that you're looking for a living donor. It's personalized, it's free, it's pretty easy to get up and running. Recipients get little cards that they can leave in a coffee shop, the YMCA, and just spread the word. And on the next slide, I'll just show you a really sweet one that one of our PEDS patients did. This little boy, 15 years old, and we were able to help him create this site. And you can see it's just very sweet and personalized with pictures. And what I like about the microsite is it has the donor support and protections built in, and it's really easy for someone to take action. So you can see if you're qualified to donate right at the top, or you can start the donor screening process and by clicking this blue bar. And also you can help the person. Maybe you can't be a donor for whatever reason, but you can share the microsite with friends and family on social media. Right at the top, there's Facebook. There's a link to Twitter, and then there's a link to email. So, and this obviously allows for the person to explain why they need a kidney. This little patient shared, they had reflux, neuropathy, and prune belly syndrome as a baby. And so we learn a little bit about the patient, and they share what they feel comfortable sharing. I've got to bring up another video that we made. This one is very special. This is actually reflecting with a little boy who has had his second transplant, and the mom was his donor. So I'm gonna press play.
Hi, my name is Ozzy. I'm 10 years old.
Hi, my name is Celine. I'm Ozzy's mom, and I donated a kidney to Ozzy when he was 2. He had a second kidney transplant last year, and his father was a donor.
I was scared, because I didn't really remember, how it felt my first time around with the kidney transplant, and I had done it at a different hospital. And based on the stories, I was nervous. Mostly the doctors stopped bugging me. It's true, don't laugh. Yeah, that's pretty much it. It's not as scary as it seems. It's kind of just like a mind game. It really doesn't hurt that much. It can be done really well, and like you're out cold, so you don't really feel anything. I mean, I can play soccer again because when I had the tube in my chest, I couldn't really play soccer because when I was on dialysis, and I got to miss like 5 months of school, which is good.
Being a donor for your own child is challenging because you want to be there with them, and you're also in the hospital for yourself. It's it hasn't changed my life at all in terms of my own health. I was happy to be able to do it. Obviously, there wasn't any question about that. You know, it is, the recovery is, you do have to take a little bit more care of yourself than I think I anticipated immediately after transplant, because I was ready to kind of get up and be right back with Ozzy. And it took a few days to kind of get to that point. But we have a very strong support network, and that was very, very lucky for us, both for our first transplant and this one. I mean, I think one of the things we noticed right away that Ozzy didn't speak to, but his energy level just kind of went through the roof immediately after transplant. And I'm really talking about this last one, because when he was so young before, it's not as much of a kind of marked difference, but he had a tough year, the year leading up to transplant. Dialysis was hard. It was hard on him in terms of his own, just kind of how he felt. And it was hard on our family in terms of trips to the hospital. After transplant, it was like night and day. We had been familiar with Weill Cornell. Ozzy's urologist has been here for a long time, since he was born. And we really wanted all of his care coordinated in the same hospital. And so we came to Weill Cornell, and we were super happy with the care we got, that we continue to get from the nephrology team and urology teams. But the surgeons were just fantastic also. I would. I think we get a lot of really personal attention here. The other center we were at was bigger, and they saw more patients, and we got great care there too. But I think we've been able to kind of get a level of kind of one-on-one care here that feels really important to our family. You know, everybody tells you it's not a cure, and that's true. Like, you take a lot of medicines for a long time. There are things you worry about forever, but it's really made a huge difference in our lives.
Oh, I love that video. That's obviously extremely powerful, and the point of our voices in transplantation and gathering our patient perspectives is we really do feel that being able to share with other families, share with other patients' perspectives, their experiences, can help build support, help them feel less isolated. And so we were very lucky to be able to film these beautiful montages with the kids, and learn quite a bit from these patients and their experiences. And so we really just hope that that's what they provide for others. As you learned in that video, that was that patient's second transplant. So again, such a important note that we know a lot of the kids are going to have more than one, and we want to make sure that they're getting a good, hopefully living donor kidney that can last them as long as possible. So again, maximizing opportunities for transplant. So living donor transplant, just a couple of facts to run by. When we have pairs come forward, we usually expect that about 1 in 3 pairs are probably blood type incompatible, and then about 1 in 10 might be immune incompatible. So the solution for these situations are, we might be able to do some desensitization if someone's got a immune system incompatibility, meaning a positive cross match. That is an option that is very contingent on the patient, and it just depends what our immunogenetic specialist thinks. There are certain pre-treatments that we can do prior to the transplant to make it safe and basically try and avoid any issues immunologically. But you know, desensitization is not necessarily easy. It increases the amount of immunosuppression the patients are on, and unfortunately, they're at a higher risk for rejection after transplant, and they're just not as great outcomes. So knowing that we have a great solution to these incompatible pairs called a paired exchange, that would probably be our best route. But Another option is obviously the patient will wait for a deceased donor, but the best option is they would participate in kidney paired donation or paired exchange. So we are very blessed. We work with the National Kidney Registry. We're actually the founding center. Um, the NKR came to be because a father actually came to our program and was trying to donate his kidney to his daughter, and they were incompatible. So this father had a very heavy mathematics background and decided that he needed to come up with a solution, and he did. He created the National Kidney Registry. They have a very sophisticated algorithm and matching system, and he was able to essentially facilitate a paired exchange, and his daughter was able to get a transplant from another person, and he was able to donate his kidney. The National Kidney Registry is the largest paired exchange program in the nation. 103 transplant programs participate, and they have done thousands and thousands of transplants nationally. They are incredible. This is older data from 2008. They've definitely done far more than 4,000 transplants. So it's a database of patients who needing a kidney transplant and their intended but incompatible donor, and then altruistic kidney donors. So they have a large pool of donors. The matching system creates chains, and then now more so we're doing voucher donation, we've got advanced donation, and things are just constantly evolving. We have a program called Kidney for Life, where they are looking at low eplet mismatching, which essentially, if you've got a low eplet mismatched kidney, you may be able to take much less immunosuppression, have a longer lasting transplant. So things are constantly evolving, and it's very incredible. This is one of the historic, like, massive changes that the National Kidney Registry did. I believe this article might have been in the New York Times. They had like a 30-person chain of transplants done, and it was across the country. It was really incredible. So a non-directed or altruistic donor kicked it off. So they started the chain, and then the patient on the waiting list who didn't have a donor, we call that end of chain, was able to get that kidney, and that's essentially like winning the lottery. So the benefits of the kidney pair donation is, again, there's this large pool of incompatible donor recipient pairs. You come forward with your mother and you guys are blood type incompatible. So your mother's able to get a compatible kidney, you're able to donate your kidney to another person, and it creates a great solution. It obviously has the potential to significantly increase the number of transplants, quicker time to transplant, and reduces negative associated things with being on the deceased donor waiting list. And it's really an incredible option. This picture I love. This is actually a little boy named Evan, who was transplanted much, much younger. And he was our first in our first chain on Valentine's Day in 2008, and he's obviously grown and is doing really well, and we love that. So pediatric advanced donation, we also have adult advanced donation as well, but basically it's a kidney paired exchange separated in time, and it's an option for patients who, say, grandparents or parents want to donate to their child. The child may not necessarily need the transplant at this moment in time, but they're able to give their child a voucher. And it is then that patient can activate that voucher and get a transplant, but the parents or the grandparents can donate at that time. And it's an innovative way to maximize transplant opportunities through donor exchange. So here's a couple examples. Again, voucher donor, he's 68 at the time. And if you wait until the recipient's ready in 10 years, they may feel that they're too old to donate, and the grandchild has been diagnosed with kidney problems and may need a transplant in the future. So they would donate in advance. Or you have a patient who has a functioning kidney transplant and may need a second transplant in the future. The father's 55 and wants to donate, but fears he'll be too old or have a medical condition that contraindicates donation. So the patient the donor is able to donate in advance. And both cases allow the donors to donate their kidney before the intended recipient receives the kidney. And the value is when the child either needs the transplant, a best of kind living donor will be available to them. So that's an incredible option. We'll just go over this very quickly because I know many of you on this call have heard a lot about living donation, but who can donate in general? So in the United States, it's 18 years or older. At our center, it's actually 21 years and older. That is our age cutoff, but certain centers will follow a different age cutoff. We don't have an age max, but anyone can be a donor. It could be a family member, a patient, a parent, a child, a brother or sister. That's called living related donation. But it also can be from a good friend, a spouse, an in-law, and that's unrelated donation. And then it could be from a complete stranger, and those are called altruistic, non-directed, or Good Samaritan donors. I just really want to emphasize, we at this point tell our patients, if you have someone willing and able to be a donor, have them register. Don't rule them out yourself. Let our team do their job, and they don't need to be blood type compatible. You don't need to say, I only need a kidney from someone blood type O, because we have the paired exchange. So we don't want you to limit yourself as to who you think could come forward to be a donor. There are certain medical conditions, of course, like uncontrolled high blood pressure, diabetes, which are obviously our two leading causes of kidney failure, and cancers and certain infections and certain mental health issues that could prevent someone from being a living donor. But what I say to our patients is really never rule someone out yourself. Take that burden off of yourself. Let us do our jobs, and we will do a very thorough evaluation. We'll never clear someone we are fearful might need a transplant in the future. Um, just with any procedure, living donation, there are surgical risks. Kidney donors typically experience a 20 to 30% decrease in kidney function after donation, but the cool thing is the remaining kidney compensates for the loss of the one kidney through hyperfiltration. And donation has not been shown to reduce life expectancy. And interesting, people who have donated a kidney outlive the average person. Then I speculate this is because our living donors are extremely healthy and they're very cognizant of their health, their wellness. They report very high levels of self-esteem and often request that they could hope to donate it again. And I have to say, no, you have to hold on to that one remaining kidney. But they feel so good about the decision they made and the act of kindness and selfishness that they've decided. So of course, we should go over some common misconceptions. Myth one is that my donor's health will suffer. So hopefully we've already squashed that, because we know that our kidney donors are healthy and they're able to have a very thorough evaluation. And typically those who donate, like I said, request to donate again. So their health does not suffer. And if there is any person who comes forward and we are concerned about their health, we are not going to clear them. And that's just sometimes part of the process. Two, living donors face a long recovery. That's a myth, because we have a single port laparoscopic kidney nephrectomy option where our kidney surgeons are able to remove the kidney from an incision through the belly button or a very small laparoscopic incision. So recovery is short. Patients are typically in the hospital for 1 to 2 days, and they're usually recovered to work about 3 weeks after. Our patients that work in like manual labor, we do request them to take a little more time off, just because we just don't want patients to get a hernia. But people do feel really great, and we have patients, they're up and walking after surgery, which is really good, because with a laparoscopic procedure, there's a lot of gas that can formulate. So we want them up and at 'em, but they feel really good. Next, medical bills will cause hardship for my donor. So thankfully, the recipient's insurance will pay for testing, and donors, of course, are never financially compensated for their decision to donate, but they do meet with the financial coordinator And just as we will never take a kidney from someone who we're concerned about their medical situation, we won't take a kidney for someone we are concerned about their financial situation, because we want to make sure that they have insurance coverage. And thankfully now there's so many donor protections in place, like there's lost wage reimbursement. So we just want to make sure everyone is okay, and we're very thorough. We do our due diligence when it comes to that. Myth 4 is dialysis must precede transplant. That is a crazy myth, because we actually like to see patients before they start dialysis. We want a preemptive patient to come forward because their outcomes are better. And we can list a patient when your GFR, your glomerular filtration rate reaches 20. We can list a patient. So if we can see you before you're needing dialysis, that's even better. And lastly, only a close relative can donate. That's false, because we know that we can have a kidney donated to us from a friend, a stranger, and we don't need that genetic match. It is nice when we have someone who comes forward and they have a great genetic match, but it's not a barrier to transplant. So in general, there are more patients waiting for a kidney transplant than those who will get transplanted each year, unfortunately, due to the national organ shortage. Living donor transplant maximizes chances of optimal patient and graft outcomes. Microsites, kidney pair donation, advanced donation are strategies to increase living donor transplant, and we really lean heavily on those options for a PEDS patient. And living donation is minimally invasive and safe for our donors. So if you're eager to learn more about pediatric transplant, of course, I could not cover the whole situation in this webinar. We have a very robust website. We have a section on PEDS transplant, and this is a nice picture of our team, some of our team members. So please visit our website at weillcornelltransplant.org. And just lastly, a little bit about our program, of course, is we are the first established program in New York, and we have done over 6,000 kidney transplants, and we are a Medicare-approved center. We seek to maximize opportunities for transplantation in order to safely transplant each of our patients by increasing outcomes and or improving outcomes and increasing access. So I couldn't do a webinar without plugging the walk. We're walking on November 10th in New York City. We meet at Foley Square and we walk halfway to the Brooklyn Bridge. It's a great day. We partner with the National Kidney Foundation. We raise money. We celebrate recipients, their families, the donors, and it's just a really feel-good day. So if you're eager to get out, meet some people, many of our team members will be there. I'll be there, of course. You can join us at kidneywalk.org/NYC/WCM Kidney, Weill Cornell Medicine Kidney. You can also send me an email if you have issues joining, but hope to see you there, and bundle up because it is usually brisk. And then if you're not already a member of our support group, I just can't encourage it enough. It's such a great group, and it's really grown since we started. We've seen patients who have started with us and they are in the middle of their evaluation, and then now months have passed and they've gone to transplant. And so everyone's welcome. It's run by our wonderful social worker, Laura. So please join us. We meet on the second Wednesday of every month at 10 a.m. and we look forward to seeing you. And then lastly, please connect with us on social media if you haven't already. We have a Instagram, a Facebook, a YouTube channel, and I work hard on making sure we're keeping people up to date on events, education, health and wellness tips, and patient stories, of course. So follow us. You can scan the QR code. And then if you happen to be on this webinar and you're not a patient of ours and you'd like to be, you can call 212-746-3099. And that is that. I am giving everyone about 20 minutes of their time, which is wonderful. And do we have any questions? I don't have Dr. Lou on today. We had our pediatric transplant medical director on yesterday, but I'm happy to do my best at answering the questions, or I will ask her. But if you don't and you were just on to learn about pediatric transplantation, it's good that you're here. And if anyone has any questions about living donation, the walk, the support group, just in general, you can type it in the Q&A box. And if we don't have any questions,
I don't see any questions, Eliza.
all
Oh,
right.
wait. One just came in. Oh, this might be a tough question to answer quickly. But someone is asking, why is there such a disparity for Black children?
Yeah, that is a tough question to answer quickly. I would like to refer back to the pediatric nephrology group just to verify. But there is also a disparity in Black adults. There's more incidence of hypertension and diabetes, and so I don't know if that's the reason. But that's a great question. And I will follow up with you because I know who asked this question and I can send you an email. Because unfortunately, I will say I'm an expert in kidney transplant for adults, but I am not in for pediatric patients. But I'll find out. You're welcome. Thank you guys so much. I think it's always interesting to learn about different patient groups.
All right, everyone. Thank you so much for being here with us this afternoon. Eliza, thank you so much for your time and expertise. And we look forward to seeing all of you next month.
Okay.
Have a great day, everyone. Thank you.
Bye.